Hello, this is Petra Rose again. This is the second in the reporting skills movies. This one is on the report framework and content. The framework or structure report is really pretty standard across different institutions, across different modalities, and in fact, across different countries for the most part. The structure report should contain the following, and we're going to go over each of these specifically: what type of study it is, the date, obviously, the indication for that radiological study being performed, how it was performed, comparisons with prior studies, then the findings, interpretation, and notifications. The study title usually comes across automatically if you're using a voice recognition system, or if you're not, it should be there on the order request. And this is very specific as it leads to the billing cycle. This is the actual study title that clinicians select when they're ordering an image. This exam name is effectively the CPT terminology, or the current procedural terminology which is used. This is a code set which is defined by the AMA, and it effectively defines what procedure has been performed, so it has significant implications for billing. So for example, for cross-sectional imaging, you don't, because somebody happens to be, you have a specific protocol that looks at CT abdominal aneurysms. That's not the CPT code. That's not the exam code. It's a CT abdomen and pelvis with contrast for billing. Same again, you don't have CT-PE protocol is not your exam name. It's a CT chest with contrast. As I said, if you use voice recognition, this usually comes across automatically. The indication should be a sign or symptoms or history which is appropriate for the indication for that study. If you are dictating more than one exam at a time, say, for example, a chest x-ray and an abdominal radiograph, you must include the appropriate indication for both of those on the indication or clinical history line. Now, unfortunately, clinicians just occasionally don't give us a complete history, and you are totally within your purview if you do not see something in the indication line, which would mean that we can actually bill for that exam, to go into the medical record and add that. In particular, it's not uncommon for us to just have rule out disease X as being the indication. This is not a billable indication. So if it says something like rule out PE, you need to be able to go in and say, tachypnea, hypoxia, chest pain, rule out PE. The indication also has to be appropriate for the exam, saying hypoxia and then head CT is not going to be a billable indication. And sometimes these can have to be quite specific. So for example, for an inferior vena cava filter, just saying DVT is not an appropriate indication, because DVT by itself doesn't mean that you can get a filter. But DVT with failure of anticoagulation is. Moving on to the techniques section. The techniques section needs to include the number of views, the area that was imaged, any post-processing that was performed, whether we gave contrast, and if it's a procedure, the procedural details. And I'm going to go through each of these in sequence. CPT codes depend on the number of views, and we have to say either the number of views that were obtained or what those views were. So either the following is equally okay for radiographs. AP lateral and oblique of the wrist, or 3 views of the wrist, either are fine. As I mentioned before, on occasions we may be dictating multiple studies on one report, and there are some fairly specific things for billing. So if you dictate multiple reports, you have to dictate that under a separate heading. So an example I said before, when you do a chest x-ray and an abdominal radiograph at the same day, you need to see chest x-ray findings, blah, 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 abdominal radiograph findings. They can, however, have a single interpretation. The other requirement is that these studies must be performed on the same day. You cannot, if somebody had a series of chest x-rays on Friday, Saturday, and Sunday, and they're not being dictated for Monday, if you don't have perhaps your institution studies, not routine studies, may not be read out over a weekend, you cannot dictate those all together on Monday. If you have multiple studies, versions of the same study, say multiple chest x-rays being performed on the same day, you have to be very clear that you are interpreting each one of those. And the best way to do this is by saying the time that study was performed at, giving the findings and the time. Again, you only need one interpretation or impression section for the whole lot, but you do need to specifically delineate the different studies' findings. In CT and MRI, we also have some specific requirements for technique. You need to say what body part, so chest, abdomen, and pelvis, for example, whether oral and intravenous contrast was given, the sequences. So, for example, if you obtain delayed sequences for a CT urogram, whether any post-processing was being performed, such as 3D reformats. What you cannot say is liver protocol or CT pulmonary angiogram protocol. Note that when we talk about a study being with and without contrast, we're talking here specifically about intravenous contrast. That doesn't mean that we shouldn't also mention whether oral contrast was given, but that billing code, the CPT code, is relevant for the intravenous contrast. And we need to say what amount of contrast was given and what type. For example, 100 mils of Omnipaque 350. When 3D reformats or other types of multiplanar reformats are performed on a separate workstation, there is a separate billing code that is submitted by the technologist, and we do that. So we have to mention a phrase such as 3D reformats were performed on a separate workstation for later interpretation or something like that in our technique phrase. Otherwise, your coders are going to send it back for you to add that phrase if we have billed for it. Similar with the dictating multiple radiographs in one report, we often dictate multiple CTs because patients have a CT of the chest, a CT of the abdomen and pelvis, maybe a CT of the head and neck and C-spine and so on in a trauma series, which are done at the same time. And it's absolutely fine to put these in one report. And in fact, it's less confusing for the clinicians frequently, but they are separate billable codes. So a chest CT is one billable code, and abdomen pelvic CT is another billable code. So we must separate these in terms of the findings, but are to confirm basically to the payers that we didn't look at all of these, but again, we can have a single impression or interpretation on the end. In nuclear medicine, we also need to make sure that we include the dose and the type of the radiotracer, again, what views were obtained and whether we obtained delayed images or dynamic images and so on. Procedures get a lot more complicated. We have to include all the equipment that we used, and this should be fairly specific. What preparation was done to the patient, including anesthesia and consent and so on, what approach we used, how many samples we took, medications we gave, any complications, and the follow-up management of that patient. And most places have, if you use voice recognition, again, have a specific template that's going to guide you through these different steps. As I said, you have to be pretty specific for these procedures, particularly in interventional radiology. So in interventional radiology, we're going to charge differently if we catheterize selective vessels. So the more subselective you are, that's a different billable code, as opposed to just, say, doing an aortic angiogram. You need to be specific about any tubes and lines, sizes and catheters that you used, the types of sutures you used, any other devices that are used within the procedure. For procedures, also, if the resident performed the procedure, there has to be a supervision statement similar to the one that I've shown you here, and that statement must be added by the staff. And again, this is because we cannot bill for many procedures, not all. There are some simple ones like putting in IVs and doing lumbar punctures that are okay. We cannot bill for procedures that were performed by residents without faculty supervision. So this supervision statement, as I said, needs to be added by the staff. In our particular voice recognition system, we use PowerScribe, then when the attending signs the report, it automatically puts a phrase on the end of all diagnostic reports to say that the images have been reviewed and interpreted by the attending radiologist. So we don't need to add that. If you don't have that, then that will also have to be added to diagnostic reports. Ultrasound also has some specific technique things that relate to billing. One is that you must mention if you are doing this ultrasound transvaginally or other endocavity ultrasound or transabdominally, or if you did both, because those are two different separate billable exams. And there are a standard set of organs which must be visualized and therefore mentioned in your report, depending on what type of ultrasound you're doing. For example, a limited abdomen for right upper quadrant. as opposed to a total abdominal ultrasound. I'm not going to go over all these specific organs in detail here, but when you're back in ultrasound, you need to make sure that you have included all of these in your report. Again, using standardized templates with something like voice recognition does really help you make sure that all of these things are included in your reports. All right, so after the very painful technique section, let's move on to something a little bit more interesting. So first of all, we're going to talk about the findings section. So the findings section should include objective information. What do you see? What do you not see? And how has it changed? The interpretation or the impression section includes more subjective information. So you are interpreting those findings, making recommendations, and then there are legal inclusions and notifications. I think it's really important that you do consider these as being very distinct, and we'll talk later about the problems when people start mixing them up. So for the findings, you want to have the major positive findings up front. So you want to answer the clinician's question first. If their big question was rule out pulmonary embolus, then you want to make sure that you specifically talk about the presence or absence of pulmonary emboli up first. Try not to bury it in the waffle. And this is actually one of the problems with templated reports, that because they are very structured, sometimes the important stuff can be stuck in the middle. My advice is feel free to cut and paste at any point. The second thing is the minor positive findings, but don't necessarily put in every incidental of no clinical impacts. Things like, spina bifida occulta has no impact. Why put it in the report? And again, we talked about patients reading their reports. If you read that you have spina bifida occulta, you're going to find that a pretty worrisome diagnosis. Particularly when you're talking about radiographs, but also cross-sectional studies, then talking about tubes and lines, followed by the major relevant negative findings, comparisons with prior studies, and then if you are doing serial indicator lesion measurements for patients who are oncology patients undergoing RESIST studies or WHO studies, then the indicator lesion measurements. When we're talking about measurements, be consistent. Either use centimeters or use millimeters, but try not to mix both in one report. And really try to avoid using 0.x measurements, so 0.1 centimeters rather than 1 millimeter, or worse, point with no initial zero. All of those are very prone to inaccuracies in translation and can be the source of multiple errors. Use an appropriate number of decimal places. Be realistic. In most imaging modalities, we do not have accuracy of measurement down to fractions of the millimeter. Perhaps the only exception to that is when we're measuring a nucleolucency in ultrasound. So generally speaking, recording something as 7.4 millimeters as opposed to 7 millimeters, more decimal points does not necessarily add to more accuracy. So this would not be a great report either for the referring clinician or for the poor radiologist who has to follow up these ultrasound nodules. You can see here that we have fractions of a millimeter measured here, which again, is really within our means of accuracy with ultrasound, generally speaking, that we have a gazillion nodules that are measured in 3 dimensions. Sometimes we use millimeters, sometimes we use centimeters, so that gets very confusing. We have 3-dimensional measurements on a lot of things that we probably don't need 3-dimensional measurements. Again, we've got centimeters down here. I defy anybody to be able to work out what on earth they need to do with this particular thyroid, and you have to hope that your colleague gets this on follow-up. There are times that we want to use 3 planes if it's clinically relevant in this particular patient and that you feel it's going to be reproducible. For tumors, if the clinicians request that you use RESIST criteria or WHO criteria, we'll talk about in a little bit, then do use these measurements specifically. Otherwise, we don't routinely. Just to mention a bit more about the RESIST criteria, these are a standard set of criteria which are used to follow patients who have cancer who are usually involved with some form of a study. Even if they have not been used previously in this patient, if they are requested by physician, then you use them. Just the short version of this is that we measure we identify uh, no more than 2 indicator lesions per organ for a total of no more than 5. And we have very specific ways that we measure these. I'm not going to go into here, but you do need to go to the Dartmouth Radiology website under Body CT, and there's a nice little um, PowerPoint there on how to do effective resist measurements before you do this. And there is a template within PowerScribe, our institution, that allows us to do these. Moving on to the interpretation or the impression section. The interpretation section is really the most important part of the report in many ways. What you want to do first of all is answer the clinician's question. Again, if the clinician's question was, does this patient have pulmonary emboli? You want to say yes or no up front, but you want to particularly interpret those findings, not just have this section be a big reiteration of every other finding you found there. The findings you want to repeat in this section should particularly be the major ones, or at least those that have some kind of a management recommendation or a management implication. In this section also goes a number of other things, any further imaging or clinical management recommendation, whether you notified the clinician, if this is a critical exam or a critical finding, we're going to talk about that, or an unexpected finding. And then you should also include notification if there have been any significant changes from a preliminary report if you're a resident. So if your preliminary report, even if it was only available for 30 seconds on the system, had a significant change when it was reread by an attending radiologist, you must contact the clinician. And you must put a line in here to say that Dr. So-and-so in the emergency room was notified about this change from the preliminary report, which said no pulmonary embolism. And the attending says there was a pulmonary embolism. And that's really important. Even if that report was only up for 30 seconds, you don't know who read it in that 30 seconds. And that notification must go on there. So what are some of the common mistakes in the findings and interpretation section of reports? Well, the first is doing the interpretation of the findings in the findings section rather than down the bottom. Remember, this is the objective part of your report. And second, and probably even more common, is repeating all of the findings from the top down in the interpretation section again. Again, you don't need to do that. Not giving some form of ordering of importance of both findings and interpretation. The patient has a 6-centimeter abscess, but it's all buried amongst some, stuff about their 3-millimeter hepatic cyst and their tiny pleural effusion and everything else. You've got to remember, clinicians are busy people. They're reading an awful lot of reports, and they may run out of enthusiasm by the time they get to item 10 of your interpretation. This was an interesting study, and it's been validated in other studies that only 50% of clinicians only ever read the interpretation section. So, if it's important and it needs to be acted on, then it needs to be in there. There seems to have been a problem for a little bit of a while. Here's some 1923 JAMA, and this was particularly talking about inconclusive reports that had poor interpretive sections. A report that does not state what the findings mean tells much, yet almost nothing. This is one of our key roles as a radiologist, not just seeing those findings, it's interpreting them, giving our opinion on them. And kind of on that thought, this is, I have to say is a sort of particular thing with me, but, the interpretation section versus the impression section. Unfortunately, impression has become the standard terminology in a lot of places in their templates for that last section. But if you look at the definition of impression, it says this: a notion, vague or mistaken belief. So, I would ask you that even if your section header is impression, let's make it your interpretation. This is part of our value product as radiologists, is our interpretation of these findings. We need to try and avoid using jargon in our impression, particularly as, those 50% of radiologists that are not reading the findings. So this is radiology jargon. It's not inaccurate, but what we really mean and what we should have there is this, right? This is our interpretation of it. Be careful in oncology reports in your interpretation. You want to try and avoid the terms response and progression because they're very specific WHO and RECIST criteria for defining something as responding or progressing. And they involve you taking a series of indicator lesion measurements, and it's what percent they added together, and it's whether they've changed a certain percentage and so on. And unless you want to be getting into that particular landmine there, I would suggest you try and just avoid those terms. So saying something's enlarged or decreased is fine. Just avoid those terms, response and progression. Some institutions include waivers such as this. Yeah, you can put them in if you want, but they probably have extremely limited legal protection and probably none. If you miss a breast cancer, it doesn't matter that you have that waiver there. You might equally be sued. If you're going to recommend additional examinations, be as specific as possible and try and use the ACR appropriateness criteria. So we're using evidence-based recommendations here. Whether you recommend them or not may depend on the referring clinician. You don't necessarily need to tell an orthopedic surgeon or a gynecologist specifically what to do, but if the referring physician was a nurse practitioner, some other mid-level provider, or a generalist, you might need to be a little bit more specific. So, for example, if I see something I think's a polyp in the uterus, I may suggest to a general practitioner that the patient's referred to a gynecologist and that a sonohistogram is considered, where I wouldn't obviously do that for a gynecological referral. So interesting, although we get worried about this, that lawsuits are actually extremely rare as a failure to recommend exam. I'll show you some data. This is just from New Jersey from a few years ago, and you can see that the failure to do additional testing was really a very small minority of the lawsuits here. There are, however, some important medical legal aspects to our report that we do need to include that I'm going to go over a little bit specifically. And while I'm categorizing these as being medical legal, they really are patient care issues in reality. So the first is unexpected findings. So what is an unexpected finding? So an unexpected finding is something that is non-urgent, so it's not going to kill the patient if the clinician doesn't know about it or significantly harm that they don't know about it immediately, but unexpected. What's unexpected? Well, if this patient has been sent for a patient with melanoma to stage 4 metastasis and you find a metastasis, that is not unexpected. However, if they were being studied for a renal colic workup and you found what looks like a possible metastasis or primary lung cancer in one of the lower lobe slices, that is unexpected. They're having a hematuria workup and you find a small renal cancer, that's not unexpected, but you find one in somebody who has appendicitis, that is unexpected. So that gives you some kind of an idea. Of course, being able to read clinicians' minds is not necessarily quite so easy. So at our institution, what we do in these cases is we dictate the words unexpected findings, and this triggers a response system that the clinician will be messaged via EDH, and they will be tracked to make sure that they have followed up on these findings. And if they don't follow up on them after several reminders, a certified letter will go to the patient. Other places have different systems. There are some which are built into the medical record or into the voice dictation system that can be triggered directly selecting that unexpected findings option. Don't ever hesitate, however, if you feel the clinician needs to be notified by phone, and then you record it, that's okay. But to be honest, most clinicians do not want phone calls about every solitary pulmonary nodule that we find on a chest CT. So you have to be, a little bit conservative with those notifications. So unexpected findings are really defined by the interpreting radiologists, and these are different than critical findings and critical tests. It is a JCO mandate that each institution will define its own list of critical findings and critical tests. So these are standard across radiologists within an institution, but not necessarily the same across institutions. So critical results require you to be able that you must inform the referring clinician and document it, as I'll show, within 60 minutes of discovering that abnormality. The critical tests are different. Critical tests are have to have the results referred to the clinicians, even if they're entirely normal, within 60 minutes of those images being required. We have a list of both critical tests on all workstations. If you look on the workstation, you'll see as critical test, and you can open it up, and each other institution should have their own lists. So when an abnormality is on our list of critical findings, or the test is on our list of critical tests, you must include that text. This is a critical test, or this is a critical finding, in your interpretive section of the report, because the search engines that report on this look for that text. And these notifications must be verbal. You cannot send this through other system. We have a little auto text macro, which is just critical communication, which will bring it up for you and just fill in the fields. And the other requirement from JCO, which always seems a little bit forced when you do it, is you must have them repeat back to you the results and then document that they did that. And the critical communication macro does include that verbiage. So here is our list of critical results. So those you have to phone the clinicians within 60 minutes of reading the study and then document within the results that you have spoken to the clinician. Obviously, this list will vary between different institutions. For us at Dartmouth-Hitchcock, it is the same regardless of whether the patient is at Dartmouth-Hitchcock or is at one of our outreach institutions. And this list is available on all of our PACS workstations, so you don't have to be remembering it. It's also available within Epic itself. Once more, this does not limit you as to the results that you have to phone clinicians. We have to use common sense here, but these are the ones you absolutely have to. And then document that this is a critical result. Critical tests are different because they are dependent on the history. So if the history is acute paralysis, and they're usually going to MRI, obviously, then this becomes a critical test. Again, these must be reported to the clinicians verbally, even if normal. So the history says acute paralysis, totally normal spine MR, you must still phone them within 60 minutes of that test being performed. Our other one is retained surgical foreign body. These are usually the abdominal radiographs that come down from the OR, exactly the same if you have to phone them, even if it's totally normal. So note, critical tests are going to be a test with a specific history, and we only have 2 of them at our institution, and most places only have a fairly limited number. All notifications should include who did you talk to, the date and time, how you communicated them, so usually by telephone, but it could be, you may have a messaging system set up at your institution, and as I said before, if there was a change in the preliminary report. So just one further thing in this particular section of the videos, the throwing under the bus verbiage. So I would try and avoid using the terms in retrospect, particularly in specific occasions of malignancy, where you think that you saw that tumor before, or using the words "it has increased" from the prior report when it was not mentioned on the prior reports. You're just going to cause a lot of trouble for another radiologist, I would suggest that you just state the findings as you see them now. So you just say that there's a 2 centimeter spiculated mass in the right upper outer quadrant, highly suspicious of malignancy, and we recommend biopsy and move on from there. All right, so that was a little painful, I know, I'm sorry, but we're going to move on to the next video, which is going to talk about the more stylistic aspects of reporting. Thanks for listening.